Here's Iype.
Partido.
Hi there. Good morning, guys. Jorge, all ready?
Hey, Iype, about 5 minutes.
Sure. I see that Sunil and Chris are here. Old friends of mine. Sunil was with me in medical school when I was doing my neurosurgery. One of the guys who inspired me to take up skull base and vascular. And Chris has been an old friend. How are you doing, Chris? Good to see you guys, Sunil and Chris.
Yeah, sometimes people hook up and they take a walk.
No, Sunil is here. I was just talking to him. And
With the jungle behind you. Where's that? The jungle.
well, this was a photo from Nepal, but right now we are located in a very beautiful place on the Western Ghats. So this hospital is truly amazing. 60 acres of very, very beautiful campus, all the facilities. So getting an Escolab lab started here as well. So maybe in 6 months, we'll have, by the time this corona pandemic is kind of over, we'll have people coming here. We can host a lot of young neurosurgeons from all over the world for dissections, life surgeries, and everything.
Oh, good. Okay, Iype, I'll just have you explain what you have in mind, right? Rather than making a video, just kind of explain, like you told me initially. You know what I mean? Yeah, just explain your reason for wanting to do this. Just what you said to me.
Yeah, John. See, there are a lot of seminars now. I mean, we started it off actually. Maybe a couple of 4 years back, we started it off. But then now it's all over the place. It's like a rash. So the thing is, I thought we have to do something different. And one of the things why we wanted webinars in the first place was because we didn't want these PowerPoint presentations from all the guys all over the world showing pre-ops and post-ops and not really being useful to young neurosurgeons.
Hold on, I save it, because I'm gonna. Okay, you can explain it to everyone. Okay, you ready to start?
Yes.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good evening, this is Dr. John Bennett of Neurosurgical TV. We have a series of Ignite interviews with Iype Cherian, I'll turn it right over to Iype. Good evening, Iype. And could you explain, like when you came to me, the reasoning behind doing these Ignis interviews, please?
Thank you, John. I remember starting webinars in neurosurgery in 2017. That was probably one of the first webinars that was ever aired with Neurosurgery TV and with us. So probably anywhere in the world, this was probably one of the first few webinars, active webinars being aired just before, even before the pandemic time. Now there are a lot of webinars, but we decided we've got to do something different. And we thought we'll get a host of, we'll get to host a lot of excellent neurosurgeons all over the world and ask them questions about their techniques. So, you know, the thing is, in one life, there is a certain set of things that you can learn from your experience. But if you combine this set of experience and nuances for the young neurosurgeons, it would be a valuable, very valuable piece of information. So we thought we'll get experts from each field and ask them probing questions about their techniques or their so-called secrets. Jorge just told me he has no secrets, but every surgeon, every neurosurgeon has his secrets. So we ask these secrets to these neurosurgeons and we compile it together. So it would be the lessons of a lifetime, 1, 2, 3, 4, 5. This would be the whole objective of this Ignite interview series. So that we all learn and we pass on this information to the young neurosurgeons.
Very good. Okay, where are we going now, Iype?
We'll ask Jorge to start on with his presentation if he is ready.
Hello.
Hello.
Good night. We think about to do this second part with the Iype because it's important to. I think it's very important to share the real surgery. Okay, the real surgery is not as clean or as clear as everybody show, because most of the surgeons, we edit the videos when we show the cases. And what we want to do today is really share about the surgery in order to the young people to understand what we're trying to show here. Okay, and that's what I will try to show you to you today. The last time we were together, I show you my presentation, okay, about the Mi Plata approach, okay, and I just want to show you some things about that day, that a couple of weeks ago. And the first thing I want to share with you again is we can publish this in the end of August, just very few days ago as well. And the other thing is it's very important to understand that this is nothing new. Okay, that's the concept. The concept, the things are there. The only thing different is the eye that you use to look at the same anatomy that everybody knows. Okay, but it's important to understand that we use microsurgical anatomy. Okay, this is not a naked eye anatomy. It's very important that, because when you, for example, when you start your approach thinking about naked eye surgery, you use to do a bigger approach, okay? Because you need, you know, the light is not so good, and you need to, you cannot see the things as you can see when you use the microscope. And it's a key that I learned from Juha, Ernest Niemi, that you must put the microscope at the beginning of the surgery. Because when you use the microscope since the beginning of the surgery, you start to do your surgery smaller, okay? And that's the thing that we changed in 2015 when we start to do the mini pterional approach, okay? Because we came to the conclusion that it's not necessary to use the orbitozygomatic approach, for example, transzygomatic approach, or transbasal approach for the surgeries that we used to do with this kind of big approaches. We start to use more the microscope and use a concept that I tried to put a name. That's not it came from the keyhole concept, but it's not keyhole concept. Okay, and then I want to fast forward these slides, but the important thing is this: okay? The change came in 2015 because the concept that I said to you about the use of the microscope and change the instrumentation. Okay, this change of the instrumentation is use the suction irrigation concept that I learned in Japan. Okay, for the Shinkai Hospital group from Rokuya Tanikawa and Professor Kamiyama. Okay, when you use the suction irrigation concept that came from the endoscopy, you can go, you can start to use a smaller approach, because the operative field is cleaner, and you can coagulate it more efficiently, and you can do your surgery smaller, because you don't need to have an assistant, okay, and in order to put the irrigation in the surgery. And the other thing is, of course, I always say that this is nothing new for me, at least as a surgeon. I always copy. When you copy and you give the credits to the people, is the thing that the surgeons do, okay, in order to make your small contribution or whatever you want to name it. But you need to say that where your knowledge came. And I started the first concept of the mini pterional came from Edgar Natal from Mexico. And he started to do this approach in 2005. He published this, and but this is a one layer flap of the mini pterional craniotomy that is very good for all kind of aneurysms, but most of in the MCA is very good. But when you want to do a skull base, I will show you the dissection that one of my former fellows did, Tomás Poblete, and you can see that when you use the interfacial dissection of the muscle, you can have a much better exposure of the skull base. Okay, and you can see the picture here in this portion is the original paper from Figueiredo and Spetzler. Exposure here, but here we have the dissection of Tomás, and you can see that you can reach the very anterior portion of the exposure very good with the interfacial dissection. And it's very important to say that the mini pterional approach is not just a small pterional approach. Okay? Most of the people think that it's important to do a small craniotomy. Small craniotomy is keyhole. But the mini pterional craniotomy is not a small pterional. It's because got an anatomical limit. The anatomical limit is the superior temporal line. Why? Because we want to avoid the frontal sinus. Okay, that's the reason why. And it's very important for reconstruction and for you have, in order to have less complication of CSF leak. Okay. And then it's very important to come with the concept of key exposure concept. What is the key exposure concept? It's an endoscopy derivation concept, because it's the smaller exposure in the outside of the surgery, but the widest exposure in the bottom of the surgery. And that's the most difficult part to do, because everybody is afraid to take out the bone in the deep. Because I have this discussion with a lot of surgeons. Everybody said to me, why is it so important to you to have a mini pterional approach? Why do you don't use a pterional? It's just bone. But when we came with the discussion about the anterior clinoid process, everybody said that it's very difficult to take out, it's very dangerous to take out, the extradural exposure is very, you have complications and whatever. But for me, I said the same, the anterior clinoid process is a bone as well. Why? When you have a bone in the deep portion, it's a problem. When you have a bone in the surface, it's not a problem. It's because of the complications, but the complications came not for the technique, came for the ignorance. If you don't know neuroanatomy, you don't know what the problems or eventual complications can be, and you have not enough knowledge of how to deal with that. Okay, and this dissection came from Tomás, and you can see here that the interfacial dissection of the temporal bone, you have a very good exposure of the anterior portion. You have here the zygomatic process of the frontal bone, the frontal process of zygomatic bone, and the good exposure that you have of the frontal dura, temporal dura. And here you have the periorbita, the orbit exposure, the lateral wall of the orbit, and the roof of the orbit, and the meningoorbital band. Okay, and this is before and after opening this, because this is one of the keys of the surgery that I will show you in a video. And it's very important because I think the opening of the superior orbital fissure and of course the middle fossa peeling is the key for this kind of surgery, for all kind of surgery, because it's a family of approaches. This is useful for paraclinoid aneurysms. This is useful for clinoid meningiomas, cavernosinus meningiomas, sphenopetroclimal meningiomas, trigeminal schwannomas, and extradural lesions like chordomas, chondrosarcomas. Even if you want to do, for example, bypass for example, in a carotid lesion in a transsphenoidal procedure that I did a few weeks ago. And I think I will show you that surgery because it's very interesting how you can expose the clinoid segment of the carotid artery using the same philosophy that we use in the Mi-Plata approach. Mi-Plata approach, the only difference with the other things that I comment to you is in this approach we use everything. But what I want to the young people learn is they can use this surgery in different fashion, independent of the patient that you have. You can expose the paraclinoid, the clinoid carotid, the paraclinoid aneurysm, or if you want to do a bypass, you can do a bypass. You can do whatever you want. Okay. And now I want to show you the rest of this anatomy, and I want to show you first a case that I operated the last Thursday. Okay, 1 week ago, just 1 week ago. The patient now is. I will show you that I had a complication in the surgery and an anterior choroidal artery infarction, but the patient is doing well. The rehabilitation just 1 week after the surgery is in the common room with the other patients, no ICU, no nothing, and with a paresia of the hand, but it's start to recovering very fast, and I think it's very important that you can see that this kind of surgery is very well tolerated for the patients. And then I want to go out this because I want to show you one last dissections that sent me yesterday, Tomás, about this surgery that I want to show you, because Iype want that I show you everything about the surgery, starting for the position and everything. The position in the surgery is very standard position. No secret about that. It's supine, and the rotation for this kind of surgery is a little bit big. 45 degrees is good, and the deflection of the head is very important in order to use the gravity for your surgery. But the most important thing is the use of lumbar drain. okay, a lumbar drain. When I operate aneurysms, I don't use lumbar drain, but for tumors, I use lumbar drain because you need a very relaxed temporal lobe, okay? And if you have not the lumbar drain and the patient had hydrocephalus, you can put a drain in the ventricle, or you can open the cistern. For example, when the lumbar drain is not working, that sometimes happens, okay? And this is the dissection in a cadaver, of course, is in order to show you how this starts. This is the craniotomy. Look at the craniotomy. It's a mini pterional craniotomy. Why? Because it's under the superior temporal line. Small craniotomy, and the rest of the surgery is about drilling in the anterior portion in order to expose the anterior clinoid and the middle fossa. If you need more extension from the to the back of the surgery behind, you can do a bigger craniotomy, or you can do an extension, because you just pull the skin and made a bigger craniotomy, and your craniotomy can be as big as you need in order to take out the lesion you want to operate. Okay, and the first thing you can see here is you have to drill the most of the dose that you can, expose the main orbital band. Okay, and you do the peeling. You cut the meningoorbital band and you expose it. You can see here very clearly in the dissection of Thomas, B1, B2, B3, and the fourth nerve. Okay, the third nerve you cannot see because the third nerve is in the roof. Okay, and of course is covered for the anterior clinoid process. You need to take out the anterior clinoid process in order to see the third nerve. Sometimes when you have meningiomas, adenomas, chordomas, the third nerve is pulled to the lateral side of the clinoid because of the tumor. But the normal anatomy is like this. Okay, you can see, you must remember as well that the sixth nerve you cannot see because the sixth nerve is inside the cavernous sinus. If you want to expose more to the back, what you need to do is cut the middle meningeal artery, and you can expose the Glasscock and the Kawase triangle. And we'll show you that in the video. And the important thing is the dura mater is covering and protecting the brain. And this kind of retraction, you can get it using a lumbar drain with no problem. And if we can see here, the first thing, because we use in the most of our patients the no drill technique of anterior clinoid no drill, because I showed you the last presentation that I think that the hitting of the diamond drill is the cause of the blindness in this kind of patients. We use no drill. The first thing is expose the roof of the optic canal. You can use a ranger of 1 millimeter at the beginning, and after that you can follow with a 5 millimeter ranger, very thin one, in order to take out the roof of the optic canal. When you have the roof, the next thing that you have is the optic strut. Okay, and after they take out the optic strut, you take out the clinoid. You can take out the clinoid in block, in one piece. Of course, that a lot of people say no. If you have, for example, a middle clinoid, ossified anterior predoclinoid ligament, it's very hard to take out the clinoid. But the thing that you must take care if you have that kind of variation in the anatomy is to protect the carotid artery. You have to remember that the carotid artery crosses in between the third and the optic nerve in the most anterior part of the triangle. The posterior part of the triangle, you have the optic nerve to the middle portion and the third nerve to the lateral portion, and in the depth of that anatomical structure, there's nothing there. The only thing you have is cavernous sinus. If you have a middle clinoid or carotidoclinoidal bone that cover all the carotid artery, you have bone, and even with the ranger, it's easy to take out the bone. It's not hard because you have not the bleeding from the cavernous sinus. And then when you have normal anatomy, you take out the clinoid, and we do the first use of fibrin glue. The first use of fibrin glue is when they start to bleed in between the carotid and the third nerve, because sometimes you open the oculomotor membrane. When you open the oculomotor membrane, I made a small hole with a dissector, and I put there the first fibrin glue, and you can use a small, very small volume, because the thing that you want to do is the coagulation of and the control of the roof of the cavernous site. Okay. The second use of fibrin glue is between B1 and B2. Okay, in between B1 and B2, you have here in normal patient, of course, when you have a meningioma, you don't have bleeding from venous content because you have meningioma. But in a normal patient or regular patient, you use here the second irrigation of fibrin glue in between B1 and B2. Okay, and after that, and I will show you in the video, if you have bleeding, the third irrigation and very important is used here. Supratracheal triangle. Supratracheal triangle. The problem is in some patients is huge, the space, and then in order to avoid use of high volume of fibrin glue that is very dangerous, we use first Surgicel. You put Surgicel inside the cavernous sinus, and after that you put the fibrin glue and you wait. You leave there and you wait and you keep doing your peeling of the mitral fossa. Okay, this is the anterior clinoid. And this is only to show you that what kind of exposure that you can have in depending of the lesion of the patient. For example, this is the frontal dura, temporal dura, and the only thing that we use in this patient was the middle fossa portion. And if you see the IC green of this patient, you can see petrous carotid artery that was exposed because I drilled the petrous bone because the patient got a chordoma. This is the left vertebral, the right vertebral, the right anterior spinal artery, the left anterior spinal artery, Iype, basilar artery. Okay, and then in this patient, for example, you can go just as down as almost the foramen magnum. And then it's very important to understand that we must use what the lesion of the patient provides to us. I heard a lot of surgeons that talk, for example, about trigeminal schwannoma, and they do Kawase in trigeminal schwannoma. The most of the trigeminal schwannoma, you don't need to do the Kawase or the anterior petrosectomy because the tumor did the petrosectomy for you. And most of the patients have not anterior petrous bone because it's already taken out for the tumor. And then it's very important to understand that the pathology give us sometimes the route to do the surgery. It's very important. And then this is the anatomy. But if you want to go more beyond that point, I want to show you other dissections because this is an ongoing work with Tomás about the dissection of in this kind of patient. This is other dissection. This is from other fellow of mine, Rafael Martinez Perez, and he made the dissection. You can see here. This is after the opening of the dura. Okay, this is without all the bone. Is the progression of the surgery is from the back, but the important concept in this dissection is the opening of the dura. The opening of the dura is in the bottom of the surgery, in the bottom. Okay, because I want the dura protecting the brain. Okay, and then what we do here is let me move this. Okay, here. You can see here the opening of the dura is just in the bottom, and you can see here the dura covering the optic canal, the subdural optic nerve. This is the left side, the clinoid segment of the carotid artery, the distal dural ring, the paraclinoid carotid artery. This is the opening going to the lateral side. Okay, this is the subdural third nerve. This is the extradural third nerve. This here. This is the fourth nerve. and we cannot see more, but if you retract this and keep going opening the dura, you have the optic nerve, the carotid artery, the third nerve, the fourth nerve, okay? And if you want to see the rest of the nerve, you need to take out the tentorium, okay? And when you take out the tentorium, you can see here all the content, but without the venous content, because we use already the fibrin glue, okay? And then you need, the most difficult nerve in this surgery is the fourth, because the fourth is the only nerve that is very thin. Most of the tumors have the intracavernous portion of the fourth nerve is half of the portion of the subdural segment of the fourth nerve. Is very difficult to dissect. But if you follow, and this is a difference with the classical transcavernous approach, the dissections that I do of the cranial nerves is from the cavernous sinus to the cisternal portion. Most of the surgeons do from the cisternals, they use a hook and a knife in order to release, for example, the third nerve. Because I use the Kameyama scissor that have a curved shape, I go in from the cavernous sinus and follow the nerves to the cisternal portion. Okay, this is dynamic. Sometimes I go from the cisternal to the cavernous, but I most of the time I try to go from the cavernous sinus, because in the cavernous sinus I can see the nerves and I can follow. And what I did with the fourth nerve is follow the nerve. When you follow the nerve, you can see that you take out the tentorium, but you have the dura mater in the back. And what you can do in this point is drilling of the anterior portion of the petrous bone, or anterior petrosectomy, or Kawase approach, and you can release the fifth nerve. When you release the fifth nerve, you can mobilize the fifth nerve, and you can drill the trigeminal porus as well. And after that maneuver, you have the dura mater of the posterior fossa, and you can take out this dura mater up to the inferior petrosal sinus. Okay, and finally, when you have this kind of view, you can see the basilar and everything. I will show you in the patient that we operated 1 week ago. And after this, you have the dura mater covering the brain, but you can open the dura mater and you can combine this extradural mini pretemporal approach, that is the Mi-Plata approach. You can combine with transsylvian root. You can open the sylvian fissure and take out the temporal lobe to the lateral side and doing a mini pretemporal subdural that is more classic view. Okay, but with this kind of view, you can see everything. And then it's very interesting because you can get this. And the difference with the classical transcavernous approach are several. No, this is a mini perional modified to mini pretemporal, and you use the most of the surgeries extradural. You can combine with subdural. Is a surgery on demand. You can drill the anterior petrous bone on demand. You can drill the trigeminal entry on the Makescape on demand. The anterior cranioidectomy is on demand, independent of the pathology of the patient. Okay, I hate when the surgeon do everything before he start to operate. For me, the surgery is dynamic, and you must avoid to do things that you don't need in the surgery, because are a source of complications, time consuming, and have morbidity that the patient don't need. Okay, and then I will show you now, because this is just anatomy, and the anatomy is very nice, but are normal patients. A patient that we operate this last week.
Jorge, 1 second, Jorge. I have a question for you right now. Before you show the real case, I have a few questions for you. Could you go back to the cadaver, please?
Which one?
Yeah. So the way you have explained is excellent. I just wanted, you told about how to put the fibrin glue at 3 places.
Okay.
when you open the dura in the basal region, you said you follow the fourth nerve from the cavernous sinus to the cisternal region.
Yes.
This is an excellent tip. Most of us, yes, we, as you said, for the third nerve and the fourth nerve, we usually open from cistern to cavernous sinus. You do this behind. You do this from cavernous sinus to cisternal segment. Excellent, very good. And now I want to ask you: do you remove the tent between the third and the fourth nerve, or how do you cut the tent at this point when you do a basal dural opening like this? How do you cut the tent, and do you remove the posterior clinoid process at this time, or do you remove it later?
Yeah. The most of the time, I don't take out the posterior clinoid. The most of the time, it's not needed. Because as I told you the last week, the last presentation, sorry, this is a lateral view. This is the main difference with the classical transcavernous approach that everybody use, Vandro, Dolens, Alecrich, and everybody. They use the roof of the cavernous sinus is the key of the surgery. That's why they need to open wide the Sylvian fissure, for example. You need to open wide the Sylvian fissure, expose the third nerve from the cisternal portion to the cavernous sinus in order to expose the posterior clinoid. But if you go from the lateral side here, you take out this dura, and you can reach the posterior fossa content from the lateral side. You don't need to take out the clinoid. You know what I mean? You take out this portion. You don't need this because you use the cavernous sinus as the highway to get the posterior fossa, like Alecrich said. Okay, it's very important that. And of course, there's no magic about the Fibrin Glue use. The main things about the Fibrin Glue is this: you need to use a small volume. That's one very important thing. And then when you have a small cavity, it's no problem. For example, the roof of the cavernous sinus, the venous content is very, very small, you know. And then with a small volume, you have very good coagulation here in between the third and the carotid. Okay. But here, look at this. This is the Parkinson triangle. It's huge. I think this is the biggest portion in the cavernous sinus of the venous content. Okay. What I do is this. I try to get the Parkinson triangle. I try to do entrapment of the Parkinson triangle, because first I put the Fibrin Glue in between the third and the carotid. After that, between B1 and B2. Okay. After that, I go to the superior petrosal sinus, and I go to the superior petrosal sinus, and I put here Surgicel and Fibrin Glue, and I coagulate. That's like I told you in the last session. And then the bleeding to the Parkinson triangle or supratrochlear triangle, whatever you need, coming only from the basilar plexus. Okay. And then what I did here is put Surgicel and Fibrin Glue and wait, because after that you can take out the Surgicel and leave the Fibrin Glue. But if you just, because when I learned with Dr. Evandro in 1998, he only used Surgicel, and in order to have good hemostasis with Surgicel, you need to use a lot of pieces of Surgicel. And when you use a lot of pieces of Surgicel, you have compression. You have compression mainly of the sixth nerve and the posterior knee of the carotid artery, the intercavernous artery. But when you use a combination between Surgicel and Fibrin Glue, you don't need to compress, because I use the Surgicel just to avoid that the Fibrin Glue came out from the cavernous sinus, and as well to use a small volume. And you need to try it, because this is the truth. You can control the bleeding. There's no problem. And when you have, for example, tumor like pituitary adenoma or a meningioma, it's easier. Okay. The fourth nerve, you need to make a decision in the surgery. For example, if the patient have normal vision, you need to preserve the fourth nerve. Okay. But when the patient have an optic nerve compromise, most of the time the fourth nerve have no function in that patient because the optic nerve is, for example, with blindness of that eye. In that cases, I just cut it, okay? But because I leave the third and the fifth nerve for cosmetic reasons, of course, because you cannot leave a patient with the eye closed. But the fourth nerve, the patient cannot tell that you cut it. But when you have normal patient, what I do, okay, when I have a huge tumor, and I show you in the last case, I cut it. I cut the fourth nerve. Because if you have a meningioma here, you need to preserve the optic, you need to preserve the carotid, you need to preserve the third, you need to preserve the fifth nerve. Why? Because the fifth nerve gives you the chewing muscles, mastication, and give you B1 with the trophic to the cornea. It's very important. And then you cannot take out the trigeminal nerve. But the fourth nerve is only give you if you look in downwards, it's going to give you a double vision. But if the patient have a compromise of optic nerve, the patient cannot tell. But my philosophy is always reconstruct the anatomy. And then if you have a huge tumor here and you try to preserve the nerve, you're going to take 3, 4, or 5 hours. At the end, it's very, very, very likely you're going to cut it. And then what I do is cut the fourth here. And after that, dissect the fourth nerve back to the cisternal portion and leave there, take out all the tumor. At the end of the surgery, I made anastomosis of the distal with the proximal end of the fourth nerve, and I reconstruct the fourth nerve at the end. Okay? But the problem is, if you have a patient with the blind of that eye, the patient is not going to tell you if you have a diplopia after the surgery. But for aesthetic reasons, the fourth nerve, you cannot tell as well if you have compromise. But for me, the philosophy is always preserve the anatomy. And then if I cut the nerve, it's not all the time. Maybe I cut 5 or 6 fourth nerves in all the surgeries, but I always try to reconstruct. I always can reconstruct the fourth nerve. Is not always possible, okay? Because it's very thin. And if you use, for example, a sural nerve is too big. And what I do when I have, for example, a fourth nerve that you lost a portion here, for example, I take out one portion, a tiny portion of B2 in the patient, because B1 is important for the cornea, B3 mastication, but B2 is not so important for the patient. And you can take one of the fibers of the B2 and use to reconstruct the fourth nerve. That's what I did. Okay, and the results in our cranial nerves is very good. Okay, and this is not my idea. This is idea from Checker. Checker, I saw him showing the reconstruction of the fourth nerve. Okay, but I want to show you a video of the patient because for me, try to describe this is very hard, and it's easy if you can see with your eyes while we are doing. Okay.
Yes, excellent.
And then we will see this case, because this case is no evasion, no nothing. Okay, this is just the truth. Okay, and this patient was operated September 30. Okay, eight days ago, and then this is the work of my fellows. Okay, this is in Spanish because I'm from Chile. Okay, but I will translate for you. For me, I give always a task for my fellows that they have to do a PowerPoint presentation of the patient just after the surgery. It's very good for them to learn about the patient. Okay, because we can see the actual surgery of the patient. Then, okay, this is a sphenopetalocleiva. This is a 57 years old. No sick patient. 3 months of. You can see here, for example, the left eye, the acuity of the optic nerve was lost, headache, and compromise of B3. Okay, with a trigeminal neuralgia of B3. And then this patient, Okay, the fourth nerve is not so important in this patient because there are very bad vision in that eye. Okay, and you can see here the MRI show you a sphenopetroclival meningioma. Here you can see. If you can see this lesion, you can tell already that the patient have a very huge tumor that had a compromise of all the sella turcica. You can see here that the tumor just reached the other side with compromise of the optic oculomotor triangle of the right side. This is the basilar artery completely involved by the tumor. This line is very important because this line shows you the tentorium, the edge of the tentorium. Then this portion is posterior fossa, this portion is middle fossa, and this other line shows you the intercavernous portion with the exophytic portion, because I told you before that you must not take out the intrinsic portion in the cavernous sinus. That is for radiosurgery or for following, okay, follow up, because that if you try to take out that portion, you have morbidity. Okay, in this patient we did as well a BTO. Okay, because it's very important to know if you have a lesion in the carotid artery, if you need a bypass. Okay, and this patient tolerate the BTO. This is the MRI, just to show you the tumor. And the other problem with this tumor is this. Look at this. The tumor is very low, have a sphenoidal sinus compromise. This is very good for CSF leak, because it's very hard to have a CSF leak in this kind of patient, but it's very hard to take out all the tumor. This shows me that the origin of the tumor is very deep into the cavernous sinus. And that's why the patient have all this compromise. Because when you have a lateral wall cavernous sinus tumor, the exophytic portion is the most important. But this unfortunately, is inside the cavernous sinus. The other thing, look at this. Let me show you here. The PCOM is inside completely into the tumor. The superior cerebral artery into the tumor. The carotid artery into the tumor. The middle cerebral artery into the tumor. Okay, and then this is a nightmare because you have several tumors in one. A posterior fossa one or petroclival, a cavernous sinus, a diaphragma cella, and clinoidal meningioma in one meningioma. And you must try to do the surgery for all the meningiomas in just one patient. It's a very hard case, okay? And then this is the coronal view. It's very interesting. You see, this is the tentorium again. And then you have half of the tumor in the posterior fossa, half of the tumor in the middle fossa. And if you see here the dynamic image, look at this. The left carotid inside the tumor, the anterior cerebral artery, of course, inside the tumor, the right one, but the tumor reached the right side. And then that's why this is very important to do this surgery, follow the patient. After that, you need to see what you're going to do with the right side, because the tumor compromised completely, and you have compression of the chiasma as well in this case. Okay, and look at the tentorium. It's completely with tumor just to the back of the head. And then in this kind of surgery, what we want to achieve is not Simpson 1. What we want to achieve is the compression of the neural structure, brain, and the cavernous sinus, of course, nerves, optic nerve, and third, fourth, fifth nerve. Okay, and then this is just to show that you have a portion of the tumor is going very down in the posterior fossa, and then just to show you what you can achieve with this kind of surgery. Okay, because this tumor is one of the most difficult that I operate. Okay, and then this is the preoperative, and this is just from the microscope. You know, this is the typical size files, and we have here. I will show you the video without any addition. Okay, this is, okay, this is the mini pterional or mini pretemporal, whatever you want to name it, because in this case it's pretemporal because you use the pretemporal root in the surgery. But we have, what you have here is frontal dura, temporal dura. This is my fellow operating because I'm left-handed and the surgeon now is right-handed. Okay, and this is the meningo-orbital band, the edge of the lesser wing, and my fellow is cutting the meningo-orbital band. You see, he followed the drilling in order to expose the lateral wall. This is the periorbita. We coagulate a little bit. This is the pemphic number 1 that we use to dissect. And then you need to drill with patient, use rongers like the anatomical dissection that I showed you before. You see, we're using the same principle. I think the same rongers, the same model, not the same ronger, of course, because the other one is for cadaver. But here you have the first sign that you have exophytic portion because the lateral wall is very short because the tumor is already here. We have tumor here already. And then we take out all the bone and we follow the meningo-orbital band and the lateral edge of the anterior clinoid, because that shows you the line that you need to cut in order to expose the lateral wall in the peeling and not cut the third nerve inside the superior orbital fissure. Here, this is the Kamiyama scissor. You can see that the Kamiyama scissor is round to the side, like a moon, you know. And here he's cutting. Now he starts to do the peeling. Here B1, B2, just the beginning of the dissection. Here, a little bit more of peeling. You see, he's cutting here. A little bit more of peeling. You need to ask to your anesthesiologist to take out a CSF, please, for the drill, for the lumbar drain, sorry. Here, we start to the process of taking out the anterior clinoid because it's taking out the optic canal, the bony portion. Here, you can see that we have bleeding because this is a meningioma. The meningiomas have a normal bleeding, of course. And here, using the rongers, this is a 1 millimeter one. Here is the optic canal. It's very clear. The skeletonization of the optic canal. You see? He followed this, and this is the optic canal. Is almost completely exposed. And here we have a huge middle meningeal artery because it have irrigation, they give irrigation, sorry, to the meningioma. And it is still my fellow that is making the exposure of the middle fossa. And he going backwards in order to try to get to B3. Okay. Look at here is very important what happened. When you want to see when you reach B3, what you can use as a sign that you are very close to B3 is when you are coagulating the dura. In order to do the peeling, you have contraction of the temporal muscle here. Look at this. The temporal muscle move because you are very close to B3. You have to be careful because you are very close to B3. Then you are very close to the median meningeal artery. Here, you see the movement of the muscle? It's very interesting. And now it's very important to avoid the necessary bleeding. And you can see here, this is a mini perional. This is the superior temporal line. You need to take out the orbit to see the optic nerve. You don't need it. You need to take out the orbit to see B1 and B2. You don't need it. You need to take the zygoma to see the B3. You don't need it. We're using a lot of retraction. We are not using. No retraction, no retractor. You see here, we are using just the extradural root. This is me, left-handed. I use my my suction irrigation system, my super suction. You see? And now I start to see what they do. I take out a little bit more bone, and now I start to drill the most that I can in order to expose the middle fossa. And I follow the peeling. I cut here the medial meningeal artery. This one is the medial meningeal artery. And I cut it. I put the bone wax in the foramen spinosum. You see, it's no secret. It's the same that everybody do. Still, I'm using no retraction. I keep doing my peeling of the middle fossa. The hemostasis is very important because it's a meningioma and that you have a lot of bleeding, unfortunately, in these cases. And here, are quite eminence. You see? And now the first stitch that I put in the dura, because we use the dura to retract the brain. No retractors in this point. Just you pull the dura and you take out CSF leak using your lumbar drain. You see, and we have a very good view, but we use microscope. You see, we have no shadow from the bone. And then I keep doing my peeling. And you need to be careful to follow the line. It's very hard because I have experience. But then the first thing that you need is take out the exophytic portion of the tumor. Why? Because you need a space. Okay, you need a space for not retract the brain. Okay, and here the first thing that you have is meningioma here already, and superficial sylvian vein. The superficial sylvian vein in one of this patient is already occluded, but you need to coagulate and cut it because the drainage of the temporal lobe and frontal lobe is still doing for the same veins, but the veins you need to preserve because the drainage of the veins are to the Iype and trolar vein. And here you have meningioma. Can you see it? And the vein. And then what you need to do now is cut the vein. Okay? Because you need to preserve the vein, the back. And I did a trick that I always do in this kind of meningioma. I coagulate the dura from the extradural portion. And then I have a retraction of the dura to the outside. And then without any retractor, I can see the brain. Okay? Because I want to avoid a lot of retraction because this surgery is going to be very, very long surgery. And then I keep exposure here at the brain, you see? And I separate the temporal lobe. I try to separate the most that I can. Here I use these clips. These clips are ABM clips because when I cut the veins, I don't like to coagulate the veins because this is a personal thinking. And when you coagulate the sylvian vein, you have coagulation, the vein coagulate completely to the back. And then I don't want that. It's very interesting. You have tumor inside the sylvian, the superficial sylvian vein. Okay? Look at the other important thing. I'm not opening the sylvian fissure yet because you need to remember that these tumors compress the sylvian fissure. And then it's very, very hard to open. First, you need to give to yourself a space, okay? And then what I do is take out the exophytic portion of the tumor. Look at this, it's huge. All this is tumor. And what I'm using the extradural part of my approach in order to avoid excessive retraction. And then what I do is coagulate this huge exophytic portion of the tumor. And after that, I cut the dura just at the level of the Kawase triangle. And we'll show you this after. Just try to explain. And what we must do now is open the dura, but like I told you before, I expose the optic canal, the dural portion, and I complete the opening between the subdural and the optic canal. because I don't want to make a lesion in the optic nerve. And the optic nerve is very, 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 very hard distortion for the tumor. Look at this. It's very, very, very difficult to find your optic nerve coming from the subdural portion. You must come from the extradural portion of the surgery. It's much safer to expose the optic nerve. And look at this. Only we have tumor here, but already I find my optic nerve. Then if you find something, you can preserve. If you don't find something, you're going to make a lesion in that. Okay? And then what I need to find now is the carotid artery and the third nerve. Look at this. Look at the optic nerve. I can see the optic nerve without any problem. Because even if we have this huge tumor, that we know that it compromises everything. And then what I need to follow is opening the distal dural ring. Okay? And then now I'm following this. But with one precaution, because I know that the third nerve is very compromised in this patient. And then look at this huge tumor. It's huge. And then another vein here is completely occluded for the tumor. Look at this. No bleed, no blood, sorry, inside. Okay? And I cut it and I keep going. This is all the exophytic portion of the tumor. I come from behind because I cut it, the back of the tumor, and this is the tentorium. Because I keep supratentorial because I want to preserve the fifth and the fourth. If you open the tentorium in this point of the surgery, you have the risk to cut it, the fourth and the fifth. Okay? And then I start to take out the tumor for portions. Here I take one piece. And then we will have a very, very nice view of the structures without any retraction. Here I'm taking out more tumor, just taking advantage of the peeling. I'm not opening the Sylvian fissure yet. Okay. And then we follow the tumor. This is the frontal lobe. The temporal lobe is here. This is only tumor. I keep following this. And now that I can mobilize the temporal lobe, I start to open the Sylvian fissure. And you must remember that you open the Sylvian fissure in the frontal side of the superficial Sylvian vein, like always, like a MCA aneurysm or whatever you want to operate. The anatomy never lies. You need to follow the anatomy. And then we start to open in the Sylvian fissure. And I will show you a little bit more. I put my first retractor. Look at, you have no problem to put a retractor here. This is a retractor showing you the Sylvian fissure. This is the uncus of the patient. This is the frontal lobe. It's very clear. And then we start to open in the Sylvian fissure. And because I already take out the tumor give me the space. And here is the middle meningeal artery. The middle cerebral artery. This is the uncal artery. This is a small one. I coagulate a little bit because it's bleeding and give branches to the tumor. And I will show you now the thing that my poor technique give me problem. And then I have tumor. This is the middle cerebral artery. I cannot see the anterior jet. This is the uncal artery. This is the carotid artery, completely surrounded by tumor. And then I know the carotid in the clinoidal segment because I see the carotid. Here is the lateral side of the carotid artery. And here, I will show you now in a few seconds, I follow the carotid artery from distal to proximal. Okay? Here, we have optic nerve, carotid artery. Here, tumor between the frontal lobe and the carotid artery inside the cella turcica. Okay? And here we are taking out this tumor to give us a space. And then you can see now, after take out the tumor, the optic nerve, the anterior cerebral artery, the Heumner artery, and here is the compression of the optic nerve. It's not in the canal, it's below A1. That's why the patient have this severe compromise of the optic nerve. Okay? And then we decompress this. We are decompressing the optic nerve, because for me it was important, because I see that this compression was very, very hard. And after that, I will come here to the lateral side. I put my retractor in the temporal lobe, and here the structures are carotid artery. The things that you need to find out here in this terrible portion of only meningioma, you need to find here the edge of the tentorium, the third nerve, the anterior choroidal artery, and the posterior communicating artery. All that anatomical structure you need to find out. And it's very hard because you cannot see nothing here, only meningioma. But here I notice B1. Here I notice the carotid artery. And then what I do is follow the anatomy, always anatomy. And then I start to take out the tumor very carefully, because the third nerve is somewhere here. And then what I found here with this, where this tiny artery here inside the tumor, and I start to dissect this artery. This artery is the anterior choroidal artery. It's tiny one. And then I follow here, and I found that if you remember that the tumor is coming from the sella turcica, this thing here, you have to believe me, is the third nerve. Is in a very anomalous position, but it's the third nerve. Okay, and then I start to dissect the anterior choroidal. Look at this. Their tumor in between the tentorial edge and the carotid. We have tumor between the anterior choroidal and the carotid. Okay, and now you can see more clearly the carotid, and we need to do a space. The only way to do a space is not using a retractor, is not the retraction of the brain. The space must give to you because you take out the tumor. And then I go to the lateral portion when I have the edge of the tentorium, and I can see here the posterior cerebral artery and the branches. I don't know if the posterior cerebral, maybe it's the superior cerebral artery, I don't know. But I know this is one of them, or the posterior or the superior cerebellar. But you need to preserve. And then I follow the arteries. Look at this. Follow the arteries and take out this piece of tumor. And when you follow this, you take out the tumor. And I was afraid of the third nerve, but I think that it's not here. And after that, I found, it's more clear now for you that this is the carotid. Completely the carotid, the optic nerve, the lateral wall of the cavernous sinus, and then we need to follow in order to find the PCOM. Okay, and now I'm opening the distal dural ring, the carotid artery. I put fibrin glue. Look at this, right? The fibrin glue that I told you in the superior triangle or Hakuba triangle, and I start to cut the distal dural ring more because I want to release the carotid artery. Okay, I know that the third nerve cannot be so close to the carotid, but here is the third nerve. Here is the third nerve, then the PCOM must be here. Okay, and remember that the PCOM was functional. And then lateral to the third nerve is the tentorial edge, and the fourth nerve is infratentorial. And then what we have here is the fourth nerve. Okay, and then I did different because I came from the subdural to the intercavernous portion of the third nerve, because it's what is so thin here, and I was afraid if I came from the cavernous sinus to make a lesion in the third nerve. And then when you think about this, in between the third nerve and the carotid, there's nothing there, and you will see that after I coagulate, and no problem. And then you can see intercavernous or tentorium roof of the cavernous sinus, third nerve, cisternal third nerve. This is the impression of the oculomotor triangle in the third nerve, and you need now to release the third nerve completely, okay, because we have tumor here. And now you can find that this is the third nerve. I know it's hard, but now you can see the nerve here. You see? Before this, we cannot see nothing, only tumor. Then remember always, anatomy never lied to you. And then I take out this piece of tumor from the edge of the tentorium to the carotid artery. No problem, because here there's nothing. Okay? And then you take out the tumor. This is not interesting. And look at this, very nice. What is this? The PCOM. Of course, it's a PCOM. Remember that the third nerve is in relation with the PCOM. And then you can see the PCOM coming to the posterior fossa in order to reach the posterior cerebral artery of the basilar artery. And then I start to coagulate because you need to release the PCOM from the roof of the cavernous sinus, because you need to release the carotid, because I want to take out the tumor from the cavernous sinus. This is the third nerve now. It's very clear now that the third nerve release from the cavernous sinus and everything. And now we have carotid artery, PCOM, anterior choroidal, third nerve, the optic nerve looking from below, and then I'm trying to see how to release the third nerve from the tumor inside the sella turcica, okay, or the diaphragma cella, because now the third nerve is flat and have tumor inside the third nerve. And then you can see here tumor, but you need to preserve the most of the third nerve that you can. Okay, even if it's infiltrated, I try to take the most of the tumor that I can. Okay, and then you can see clearly the anatomy. The third nerve, very compressed. It's not a beautiful third nerve. I'm sorry, but this is preserved. This is third nerve. This is the carotid. This is the PCOM, the anterior choroidal. You can see the anterior cerebral and everything. And then I try to decompress more the optic chiasm, and then I coagulate a little bit the tumor. But you need to be careful, because in the bottom of this dissection is the pituitary stalk. And then what you need to do is just take out the tumor below the diaphragma cella, coagulate, and preserve the pituitary stalk. Because if you take out that, the problem will have, the patient have a lot of problems. And we preserve this. This was the pituitary stalk in the front, in the bottom of the field. Okay, and then look at this. No retraction. No retraction. Just the anatomy of the patient. Okay, and now we have the third nerve release, the carotid artery release, the pituitary stalk, the optic nerve, the anterior cerebral, the middle cerebral. Okay, and now we need to work the cavernous sinus. And then I made this icy green. You can see the PCOM, the anterior choroidal, the anterior cerebral, the middle cerebral. Everything is preserved, even the irrigation of the optic nerve. It's okay. And then this is one of my tricks. Okay, when I cannot see the fourth nerve because it's too hard to infiltrate, what I do is opening the Meckel's cave. It's much easier because the Meckel's cave is huge. And then what I do in this patient is open the Meckel's cave, because the Meckel's cave is always on a space. And then you can open from the Meckel to the edge of the tentorium with no problem. Okay, and I start to open the Meckel cave because I know that the patient have tumor inside the Meckel cave, because in the coronal MRI you can see tumor below and up to the tentorium. Okay, you need to remember the MRI. And then what I do is release the fifth nerve of the patient. We have tumor inside the Meckel's cave. We take out that tumor and we start to work in between the roots of the fifth nerve. Okay, and then we follow this. This is the fourth. This is the fourth nerve here. Okay, and then because I have this huge portion of the tumor, I decide to cut here. You need to be careful, because if you cut in this direction to the bottom, if you are not careful, you can cut the carotid artery, the posterior bend of the carotid artery, and then you need to be careful. And what I do in this case is I put the Doppler and I look at this, and I try to be careful with the carotid, but in this case, we have a carotid that is small, and it's almost impossible if you follow this angle to the posterior fossa to take the carotid. But you need to be careful, okay? And we are taking the tumor here to the posterior fossa. Look at this. And now we have the compression of the brainstem. And then we go to the back, the back of the tentorium. We cut to the back. Look at this. And we take the huge portion of the infratentorial portion of the tumor. And we cut here the tentorium. And we will find the fourth nerve in the bottom of the field. I follow. And when I found the fourth nerve, because I knew that I cut it already, I tried to follow and find the cisternal portion of the fourth. Then I will show you here. We take here, this is tumor inside the Meckel scale. The fifth nerve is here, coming here. You need to preserve the fifth nerve. And then we are taking the tumor, preservation of the fifth nerve. This is the fifth nerve. This is tumor. And the fifth nerve is coming, you will see in a little bit, in a little seconds, that is coming from below because it's of course you have a distortion of the anatomy, okay? And then we have the brainstem. Now I show into the brain. The fifth nerve is decompressed. The brain have a little concussion, but it's not swelling or nothing. This is the dura. I'm taking the dura in order to show that you can mobilize the dura. And after that, using the surgery, and I will show you what the reconstruction of the nerve. Here, I want to show you this is real surgery, okay? This is the fourth nerve here. Here is the fourth. The third is preserved, the fifth is preserved, the carotid, the optic, but the fourth I cut it. And then what I do is release the nerve the most that I can from the brainstem. After that, I release the nerve in the cavernous sinus. It's impossible to put a stitch in the fourth for me. I don't know if other surgeons can do this, but I can't. I try a lot of times. And what I do now is use like shaker fibrin glue. And then you can see the fourth coming here. And I put fibrin glue, a lot of fibrin glue. I will show you here. Fibrin glue, and the fourth nerve is reconstruct, and I cover everything. Okay? And then you can see the anatomy. Third nerve, carotid, optic nerve is decompressed, pituitary stalk, posterior fossa, fifth nerve, and fifth nerve coming from the pons here. I didn't take the Kawase triangle because this patient have a lot of tumor in the posterior fossa, and I rather prefer in this case is so big. After that, I will come for a retrosigmoid approach, and I can see much better the facial nerve. Okay, because for me the preservation of the facial nerve is very important. Of course, you can drill the Kawase. Of course, you can open the dentera auditory meatus. But for me, it's good enough this decompression in the patient, and after that, you can come from the posterior fossa with a just regular retrosigmoid approach. The reconstruction is very important. We use facial temporal fascia, okay, and we use the fat that you have in the interfacial approach, in order to put this fat in the middle fossa, because the CSF leak points are important. The points of CSF leak in this kind of surgery are the medial wall of the optic canal, not in this case because you have tumor, but in there's cases that you can have that. The optic strut in between B1 and B2, the tegment tympani, and the station tube of station tube or hearing tube. Okay, and then if you cover with fat the middle fossa, you cover everything. And after that, we put muscle in the optic strut In this case, we put a little piece of fat, and everything's okay. And then we use the temporal fascia, and this is made for the fellow, and we reconstruct just to the edge of the bone. We don't go to the bottom, because it's very important for me that the temporal bone have a lot of space if you have, for example, a swelling because of venous compromise or anything. But most of the cases, nothing happened. Okay, and I will show you now the, I think we have the post. I just have I don't have MRI yet, but I will show you in the future. But you can see, you don't need to show you MRI because I take a lot of tumor. You can see in the video of the surgery. And then this is with, I asked to the fellows to ask with the contrast, and you can see here. Look at the amount of tumor that we take out. You have preservation of the become, carotid. These clips are the clips that we put in the venous, the superficial sylvian vein. But I have, unfortunately, anterior choroidal artery fracture, even if I have a good ECG, even if I try to not to do a population of anterior choroidal, because this surgery is not easy. And even if you try to do everything right, the things never go as you ask or you want. Okay, but the patient is now in the regular room and start the rehabilitation. Have follow orders, move the 2 legs, and have a paresia most in the hand. But she can already move a little bit the hand. And I think that this patient recovered, okay, because we just have 1 week of the surgery. And then you can see here, it's very interesting here because the coronal, you can see the tumor we take a lot. Look at this. Remember that the tumor you have, all the tentorium, supratentorium, infratentorial, we have here just this. This portion is in relation with the facial nerve. That's why in this case, I leave this portion for a second surgery. Okay, I rather prefer to do the second surgery. And just to show you that if you remember the MRI, we have a lot of tumor in the posterior fossa, in the clivus, and here we take out most of the tumor. We have the basilar artery free, and we take most of the tumor, even the tumor in the cella. Okay, and that's the last case. I want to show you, if I can show you other case.
Jorge, excellent, very good, very, very good. With a small craniotomy, you have what you have managed is excellent. Now, a few things for the young neurosurgeons here. You opened the Meckel's cave, and then you combined, that was extradural, and then you combined it with the dural opening, intradural dural opening.
Yes.
Then, so what you have done is you have opened out the V1 and V2, and then you have opened intradurally, you removed the tent and the tumor between the 3rd and the 4th, and then you have gone posterior, I mean, between the, behind the root of the trigeminal, that is retrogazerian part of the trigeminal, you have gone between that and the brainstem, and you have removed tumor. So this is excellent because I didn't see you cutting the tent as such. Did you cut the tent to reach to the infratentorial portion?
Yes. The problem here, Iype, is there's no an actual tent. You know, you have just tumor, and even in this case was ossified. There's bone. The tent just have bone inside. When you have a smaller tumor, or when you have a posterior fossa pathology, for example, I don't know, epidermoid cyst or something, the tent is normal, and then you can see everything, okay? Because it's very thin. But in this case, it's a huge tumor, and then you need to make some guess where the tent is, you know? And the good thing that show you where the tent is are the nerves. Because always when you follow the nerves from the cavernous sinus to the cisternal portion, you always have the nerves in your view. And it's harder to cut it, you know? Because if you try to come from the cisternal portion to the cavernous sinus portion, it's very hard in this kind of tumor because you have nothing. You have just tumor. Okay, I operate this kind of tumors. I operate before 2015 from the Almefti for the pre-sigmoid approach. Okay, I did a lot, 100 cases, but me always the problem was I have the nerves at the end. You know what I mean? At the end of the surgery, okay, the fifth nerve, the fourth, the third. But now, for me, it's much better as a surgeon because I can find the nerves in the beginning of the surgery. And what I need to do is use microsurgery in order to preserve the nerves because I already have under my view. Okay, and this is much more clear for me. You know what I mean?
Another thing I wanted to tell you, as well as take note to the neurosurgeons, young neurosurgeons, is that when you open between the 4 and the V1 or the 3 and the 4, and you go back, you can find the C4 carotid transitioning to the C5 carotid. That is a horizontal intracavernous carotid transitioning into the vertical paraclival carotid. So that's the top of from the top of the paraclival carotid is the meningohypophyseal artery. And this is one of the major supply for these tumors. And I saw that the way you were coagulating, you are going parallel to the posterior bend or the paraclival carotid. And this is something that you need to visualize. If you don't visualize, it's very, very easy to go and injure the carotid. And this can be, disastrous. So this is also something that I mean, obviously, we are trying to have the navigation to tell us where exactly the carotid is, but sometimes in altered anatomy like this, the posterior bend of the carotid is a bit difficult to figure out. But taking out the meningohypophyseal artery in this time, at this point, is very important because that supplies the tumor, and when you take off that artery, you are literally devascularizing the tumor.
Yeah.
Professor Goyal is here. I don't know whether he's in the panel. Professor Goyal, would you like to?
Yes. Yeah, Dr. Mura, that was a very great presentation. I'm very, very happy to hear that presentation from you. Unfortunately, I couldn't hear the whole story, but I saw your dissection and I saw your concepts, and I congratulate you. And Dr. Iype, it was a wonderful, organization of this meeting, and I also congratulate you, Iype. I unfortunately didn't go through the whole story, but I saw the dissection and I saw the, reduction of the exposure that was based on anatomy. And as we have discussed on hundreds of occasions, how important is the anatomy, how important is the understanding of the tumor, how important is the understanding of the way of dissection. And that's all what I have to say. Congratulations to you, Dr. Mura.
Thank you very much. For me, it's an honor to be here, hearing my surgery. Thank you very much. My camera is, I don't know what happened. It's dead. It's impossible to start video. I don't know why. It's failure of my camera. But
I have Chris here. Chris, are you still there? Chris, are you here? Chris has been with Charlie Teo, and they have their way of doing these petroclival tumors through the nose. So I am not somebody who would always advise this, but Charlie has been doing a fantastic job. I've seen his pre-op and post-op scans, and Chris has spent time with Charlie. Would you like to say something about going at these petroclival tumors from the nose? I mean, Jorge and myself and Dr. Goyal, we really wouldn't recommend, or we I don't know much about. I mean, we do endoscopic work, but then really don't go into the petroclival region for this. But Charlie has done some excellent. I mean, I've seen Charlie doing some very good job with the petroclival tumors. And if you would like to say something, Chris, are you there? Yeah, I guess it's not there. Maybe Jorge should continue. Maybe Jorge should talk about the part where he can get into the transcavernous region to take out aneurysms. He said as low as the vertebral basilar junction. So yes, we also use for low-lying basilars, we use transcavernous. We take out the PCP, and then we clip these aneurysms through the transcavernous route. So Jorge can probably go ahead and probably show us some of these videos where he's done this vertebrobasilar aneurysms or superior cerebellar aneurysms through this route.
Okay, I will show something first that is very important. The concept of, I want to show to you that this is a very versatile surgery. It's versatile, okay? I will show you a very interesting case that I'm going to share the screen. Okay. This is because sometimes, I always say this, sometimes from bad things, you can get good things, okay? I will show you. This was a patient that was operated for a typical, very for a friend of mine, and this is a patient operated several times for transsphenoidal surgery, acromegalia. Okay, acromegalia patient operated several times, radiotherapy, and very symptomatic patient. Okay. Very bad view, 61 years old, a relatively young patient, okay? And then in September 16, just 1 month ago, less than 1 month ago, during a transsphenoidal endoscopic approach, was an incidental rupture of the left internal carotid artery, okay? And they came to the endovascular suite, and look at the case. Terrible case. The compromise, both carotid arteries, the two cavernous sinus, very, very complicated case. Look at this, a posterior fossa portion and everything, okay? And this patient, my friend made, he have a huge experience in transsphenoidal surgery, and made, this patient was, everybody said this complex case, but was symptomatic and everything. The carotid, the left carotid, you can see that is not very close to the midline, but it's a little bit more. The left carotid artery got this curve that they're compared with to the right side, and then happened something that nobody want to happen. Okay. And they got a rupture into the endoscopic surgery, and then you have the contrast inside the tumor and the bleeding. And then the endovascular came to the picture, and when you need to do what is need to be done, and you can see here the patient is very complex, because this patient, the tumor, have a chronic compression of the carotid artery, and the patient have anastomosis between the external carotid artery and the cortical brain, because the patient have a chronic occlusion of the MCA, It's terrible case because I got an ischemic patient combined with a lesion in the carotid artery. Okay, and then the endovascular occlude the carotid, and then they called me, and I said, okay, this patient got a ischemic changes in the examination of the patient, and I operate with this patient the 3D microscope, but I don't have how to show you in 3D, but I show you in 2D. This is just to show you this is the same surgery again. This is a left side mini terional or mini pretemporal approach. Look at this, the same thing, the cut of the meningoorbital band, take out wing rongers, take out the anterior clinoid. This is my fellow because it's again is right-handed person who is operating, and this is the decompression of the optic nerve. This is the optic nerve. This is the Hakuba triangle. Okay, and this is we start to do the middle fossa. Why? Because I want to have control of the meningeal artery that I cut it because I'm going to revascularize the patient. And we start to do the same surgery, but the good thing here is we have tumor that replace the cavernous sinus. What we have here is optic nerve, clinoidal segment of the carotid artery, third nerve, intercavernous body. It's the same thing that I showed you in the previous case, but this is different because here is more clear the anatomy. This is the fourth supratrochlear triangle. This is the clinoidal segment of the carotid artery, and I don't want to put more ischemic brain in this picture. And then I said, okay, the carotid is occluded, and then I'm going to do the bypass to the clinoidal segment of the carotid because I don't want to compromise the PCOM or the anterior cerebral artery. I want to the patient that keep all the irrigation that the patient have, and then I go into an already occluded carotid artery, and then I found the carotid artery into the cavernous sinus. I used the ultrasonic aspirator in order to take out a little bit of tumor here, and here you can see the carotid artery. This is the third nerve, fourth optic nerve. We have coils inside the clinoidal segment, but I can release everything because it's already occluded. And then you can see no retraction again. I open the dura. I release the third nerve. Here is the third nerve is released. The fourth nerve I expose because I need to occlude here with a clip the artery. I open the distal dural ring. This is the ophthalmic artery. I release completely the carotid artery. Here I'm proximal, of course, to the PCOM. Okay, look at this, the same anatomy. Just it's a smaller surgery. It's not so complex than the surgery before. Okay, and then I don't know what happened here, but I think we tried to do an IC green, and we don't know how because this microscope is a Mitaka microscope. You see, and okay, I need to go to the next video, and it's a little. These videos are too heavy, and then there's a lot of information, and then no addition. Okay, this is my radial artery. I prepared the radial artery. I know that we're going to talk about bypass the next session, but I want to show you this because skull base is useful for everything. And then what I do, I prepare the radial, and I put my clip proximal to the ophthalmic because the ophthalmic give to the patient irrigation as well. And you can see coils inside the carotid. And then we have we need to take out the coils because I want to do the bypass. And then I take out the coils. I put a clip because I'm very optimistic one. Then I put a clip proximal to the clinoidal segment, distal to the coils that I take out, because if the patient tolerates everything that we're going to do, my friend need to go back to the transsphenoidal, and the coils are in part inside the nose. And then he can take out the coils without any trouble because I put the proximal clip in between the third and the fourth nerve, okay? And then what I did, a suture of the radial artery in the clinoidal segment of the carotid. And then this is regular suture. The time is no matter because we have not putting more ischemia in the patient because we are using an already occluded portion of the carotid. After that, I came to the neck, and I want to show you that the things are never like you want to be. We're going to occlude the carotid artery because it's already occluded by the coils, you know. And then what happened? Here we can see that the carotid is completely okay. The irrigation of the optic nerve is okay. Then we have a still patient. But when I open the carotid, look at this. The patient got a atherosclerotic plaque in the carotid artery. And then I had to do an endarterectomy of the patient in the neck, take out the plate. Then this surgery was a nightmare because have complication over complication. But it's good because I have occlusion of the carotid in the distal portion. And then if you remember, if you take out the plate, the atherosclerotic plate, you need to concern about the dissection distal. But here we have not distal portion, just proximal. And then I said, okay, I need to open the most that I can, the carotid. And after that, do the suture, and it will be okay. And then we made the suture, the atherosclerotomy with the radial, and the suture. Here is the icy green, Doppler, and the bypass is here. I use always low volume of icy green, and then that's why it's not so bright. But you don't need to see a bright. You don't need to see that it's working. Okay. And here you can see the bypass is working. The carotid is filling. The MCA is filling because you have temporal or frontal lobe, and you have good feeling the ophthalmic and the optic nerve of the patient. And then this is a bypass between clinoidal segment of the carotid artery and the internal carotid artery using the cavernous anatomy that we just explained in the tumor before. And this is a mini pterional craniotomy. You don't need more space. You have the space. You need to use the space of the pathology and the surgery that the patient needs. And this is the postoperative studies. And you can see here, this is much better because it's the coronal one, much better. And you can see here the bypass, you see, is coming to the clinoidal segment. And then you have the clip proximal. And then we can reconstruct very nice and with preservation of the anterocerebral artery, the PCOM, everything of the patient. No more ischemia for the patient. Of course, this patient made in the MRI. This is the CT angio, and the endarterectomy was very nice because the internal carotid is okay, and this is the radial artery, and you can see the patient have an occlusion of one branch of the MCA before the surgery. Okay, this patient have ischemia already, and then it's impossible to leave this patient without any bypass because the patient is going to, for sure, a carotid infarction. This patient have a limit infarction between the circulation because have a ischemia of several hours, but now is no motor deficit, obeying orders and everything. And now this is just 3 weeks ago, and we are waiting for the recovery of the patient for what we're going to do with the acromegaly with my friend that operated the patient. This other case, I think, that show you that this kind of cell is very versatile. You can use the cavernous sinus for a lot of things. In this case, to a proper revascularization of the patient. Okay.
Excellent. Jorge, excellent. I think we have to wind up, but I'm thinking maybe one more.
I can hear you. It's the
Can you
volume.
hear me? Can you hear me?
No, no. The rest, hear him?
Can you
Something
hear me?
happened. No, we are 100%.
Can't hear you.
Can you hear me?
Not as well as before.
Yeah. Very low volume.
Can you hear me now?
Yes, it's
Yes.
better.
Now it's okay.
Hello, can you hear me?
Yes.
Yes.
Okay, so what I am thinking is we will have one more session because it's so interesting. Today was very interesting, and I'm sure a lot of young neurosurgeons will find this extremely interesting. So I'm thinking maybe one more session on transcavernous, and then we'll go to the bypass. So the next session, maybe we can dedicate it for some cadaveric dissection. I can also show some of these transcavernous, and maybe Jorge can show some cases. Maybe I can show a few cases where we've gone transcavernous and clipped off the meningohypophyseal for some dural AVFs and maybe some other cases. And no, of course, not mini craniotomies like Jorge does, but standard craniotomies. So we can do that, and plus vascular cases that he's done, transitional aneurysms and maybe vertebrobasilar aneurysms that he's done through these cases. So one more session, I think, is in the offing. After that, we'll go to bypasses, as Jorge has already shown one. Excellent, very good job. I congratulate you on this excellent job. Thank you very much.
Thank you.
Okay, very good. So I guess a couple of weeks, Iype, is the next session.
A couple of weeks, I'll
We
talk to you.
name this Mi Plata 3.
Yes, absolutely. Mi Plata 3.
Mi Plata 3.
Yes, yes.
Okay.
So this series we will edit it and put it as 1, 2, 3, and once it's published, this will be like a Wikipedia, this encyclopedia for the minimally invasive transcavernous approach.
Okay, very good. We'll keep in contact and let everyone know when it's occurring. So thanks, everybody. It's good to see the king out again.
Byron,
Thank you.
Yeah. Yeah, John, everything okay?
Yeah, everything's great. It's good to have you here. I hope you have become part of this.
Yeah. So that was a great presentation and great work and very big enthusiasm. Unfortunately, I had never really encountered such wonderful work from this. I'm sure this is a big name in Mexico and the rest of the world. And my best wishes to you. I look forward to the second session of this same presentation and to the third presentation. And congratulations to you, Dr. Mura and Dr. Iype. Thank you very much.
Okay, we'll see you the next time. Thanks, everybody. Okay.